Thank you for joining us in our presentation over OT staffing in acute care. Our community partner is Amanda Hoffman, who is an OT and inpatient rehabilitation supervisor at the University of Colorado Hospital. Our needs assessment team consists of myself, Dara Rogers, Emma Tighe, Winnie Schultheis, and Taylor Babcock. For our frame of reference, we decided on the Person Environment Occupation Model, or the PEO. The PEO model acted as a guide when moving through our needs assessment process. It provides a client-centered framework that also aligns with UC Health's mission statement. UC Health's main mission is to improve patients' lives and to put the patient first. This framework encompasses that value of client-centered care and putting the patients first. Another value UC Health has is excellence. This model allows us to stay focused on our intended outcomes, which will assist UC Health in providing that excellent quality client-centered care.
First, we had a look at the prioritized needs of our community partner and those it serves. For our level 1, we identified it as the quality of care that the UC Health patients who are receiving OT services. So the patient quality of care is directly impacted by the services they do or do not receive. For example, a study by Rogers et al. Found that OT services in the acute setting can increase patient care and decrease hospital readmission rates. However, another study found that 66.5% of patients who are identified as needing OT did not get a referral. Our level 2 need is the lack of OT representation due to staffing ratios during the normal census, and that is 2 PTs to 1 OT. And the lack of representation can also lead to under-resourced or not having enough resources, which then leads to the OT staff feeling overworked and unable to give each patient the highest quality of care due to the time restraints and the caseload. And our level 3 need is an organizational in nature, and our hospital reimbursement, referral system, and business value of OT. These level 3 factors were identified by scrutinizing the OT referral process, the time constraints, the hospital reimbursement policies, and the lack of education and advocacy for OT. The productivity during normal census is 50% compared to 30% during COVID. And the consequences of not addressing the needs could lead to missed or inappropriate referrals from nurses and doctors, meaning decreased patient quality care, hospital readmission, as well as inappropriate and unsafe discharge. In order to really meet the need of level 1, we first have to kind of address level 2, which is what our program's main thing is. For the underlying causes of the needs, here is the flow sheet that we made. It is kind of breaking down the needs of our level 2, which is the OT patient ratio, and also shows our level 1 need of the patient quality of care, and breaking that down by causes. The need of a more streamlined referral process and OT staff to patient ratio is caused by the underlying issues regarding productivity standards, health professionals' understanding of OT, hospital reimbursement standards, referral methods, and OT representation. And the ethical tensions related to working in acute care develops from pressure of productivity, inadequate time for quality practice, insufficient staff, excessive caseloads, and a lack of resources.
And so on this slide, this is our logic model, and we're really going to go into the two last columns and outcomes and impacts later on. And so I'm going to just focus on the first couple here by noting that throughout our process, as Emma just touched on the needs, we really put our focus on the referral process. And so basically what we've decided that we need is we need time from nursing to learn, from an OT or a PT to teach, and from an epic analyst to design and embed this system, as well as collaboration between a multidisciplinary team to really address how we can confirm these order consults so that they're not modified based on one person's experience. And so these lead us to our activities, which is going to look like a 1-hour workshop for nursing led by an OT or PT member. It's going to look like the Epic analyst spending the time to actually embed the algorithm within the system and part of the nursing workflow, as well as a team meeting between multiple disciplines to really just confirm how we should go about settling on order consults, as well as modifying them as time goes on. And so the system is going to look like a referral process that's going to trigger or block a rehabilitative consult that gets sent to the MD. The MD then is going to sign off on it, and it's going to be sent directly to the inpatient manager, and he is going to triage it to either OT or PT based on what the referral process tells him. And so this is going to make rehabilitative evaluation ordered on the day of admittance, and it's also going to help create a system where there's a systematic reasoning for why someone is referred and why someone isn't.
Now I will be discussing the implications for occupational performance and participation in the people our need serves. The consequences of not addressing the needs could lead to missed referrals as well as inappropriate referrals from nurses and doctors. Without a streamlined referral process, this could lead to inefficient use of time, resulting in occupational therapists using important time during their workday evaluating patients who do not need OT services. If OTs are not able to see the appropriate patients, those patients could miss out on the appropriate discharge recommendations given by OTs, which could lead to readmission to the hospital if that individual was not safe to discharge home. If a patient needs OT and does not receive it, obviously they're not receiving the highest quality of care and will have difficulty reaching their full potential for occupational performance at discharge due to receiving less exposure to rehabilitation while in the acute care setting. This process can also improve role competency through providing nurses and doctors with a better understanding of who does and does not need OT services. Overall, through this new referral process, patients in acute care will be able to receive appropriate OT referrals by more easily identifying patients who need OT services through this role competency. This will lead to more exposure to rehabilitation for patients who might be missed otherwise, and more efficient use of time for OTs to focus on improving a patient's occupational performance and recommendations for a safe discharge plan.
So for our overall program goal, we hope to implement a sustainable referral process to maximize the number of appropriate OT patients through functional performance-based algorithms and service ordering protocols. To support this goal, our objectives include utilizing a functional performance algorithm that's derived from evaluative screens, which will more accurately identify patients who will benefit from OT. We also will develop a streamlined ordering and triage process based on referral recommendations from said algorithm to optimize service timeliness, ensuring patients receive an OT consult within 24 hours. We also will create more manageable and effective OT caseload through prioritized and timely allocation of services to those appropriate patients, which will reduce OT burnout and stress. And then finally, we will collaborate with a multidisciplinary team biannually to address possible changes for the ordering and referral process, and to communicate between the disciplines about OT service needs and expectations.
And this brings us to our anticipated outcomes and impacts. In terms of addressing our outcomes, we hope to address occupational performance by making sure OTs are identifying and seeing the appropriate patients. Role competency, we hope we're supplementing the knowledge for those making referrals who often report that in their education, they don't receive much information about what OT is or does. And we also hope to impact quality of life in terms of the OTs by having a more effective triage, which will in turn make a more effective caseload by creating a sense of team within the rehab services, by triaging effectively and having PT and OT work together. And additionally, for patients, through enhancing the quality, safety, and efficiency of their care by allowing OT to see the patients that they need to see in a very efficient way. And then additionally, in prevention, as OT is one of the few things when invested in that can reduce hospital readmissions. And then further, in terms of our impacts, we really want to highlight that this could potentially show that OT is expanding into new patient populations. It's going to provide a system of data collection that can give evidence for the need for an increase in OT staffing. It's going to provide a sustainable algorithm that can be editable over time as needs change. And our community partner reported to us that she's going to use our project to go ahead and apply for the Institute for Healthcare Quality, Safety, and Efficiency certificate from the University of Colorado.
So in order to kind of make this program possible, we have to look at the required resources and the anticipated cost. So on here I have personnel. It's for the training, there needs to be release time and reimbursement for that time. So each, there will be one occupational therapist from the rehab team to represent the team, who is going to then learn from a Epic analyst who has to create the algorithm and train the occupational therapist on how to use it, who will then train all the nursing staff in acute care. There will also need to be reimbursement for the multidisciplinary group members to meet. And the costs for this kind of all vary with the income of each professional, but they will each be getting half of their hourly rate. And the IT member will also get full income for actually creating the algorithm and half for training. The multidisciplinary team will also, they'll need to meet to confirm order sets and allow time for all disciplines to voice their necessary modifications to the consults. So this will be a biannual meeting. And so for the release time cost for trainings will depend on the income, but the goal of this is to properly and efficiently train all professionals on the new process to effectively refer appropriate patients to OT. Once the algorithm is created and all professionals are trained and they meet for order consult modifications, there will be no additional cost, which allows for capacity building and strengthening the sustainability of the program and allowing them to actually focus on the care of the patients. This new referral process will ultimately save the hospital money by optimizing patients' level of function and health for discharge, optimizing the discharge placements, and lowering readmission rates, and enabling higher patient satisfaction. Questions?